Well, hello everybody and welcome to another episode of GU Cast. This is Declan Murphy, urologist here at Peter MacCallum Cancer Centre in Melbourne, joined as ever by my co-host Renu Eapen. Hello Renu.
Hello Declan, great to be back.
Yes, nice to be back, and nice to be back with another contentious topic, or slightly contentious I would say. We want to have another robust discussion today.
It's been an exciting week for renal cancer though, you know, a long-awaited trial gets published.
Yeah, it is. So that's what we're going to talk about today, a really big landmark study, Keynote 564, which was presented in plenary session at ASCO, which is always a big deal if something gets into plenary. We love seeing GU in plenary. And now recently, just last week, published in the New England Journal of Medicine. So it's a fantastic study to talk about, certainly big implications for practice change. So it's really good to be able to feature this paper today, isn't it?
Absolutely, brand new, just 8 days ago it was published.
Yeah, fantastic. And we're welcoming back one of our old friends into the studio as well, Dr Ben Tran, GU Medical Oncologist here at Peter Mac in Melbourne. Ben, welcome back.
Thanks for having me, guys. I thought you'd forgotten about me. I haven't been on for quite a long time.
Ben, fresh from the makeup chair, looks great. Welcome back, Ben.
Thank you, Ben. And Ben leads our GU MedOnc team and is head of the GU Clinical Trials Unit here at Peter Mac. So thanks very much for coming back, Ben. And we would like to then welcome our international guests as well. We have the great privilege of welcoming Dr. Toni Chouieri, who is first author on the Keynote 564 study. So, Toni, welcome to GU Cast. Thank you very much for joining us.
Thank you for having me.
And also on screen here as well, you can see old friend Dr Alex Kudikov, urologist and chair of Urologic Oncology at Fox Chase Cancer Centre in Philadelphia. Hey, welcome back, Alex. Nice to see you.
Thanks for having me. What a privilege.
It's great to have you, Alex. We're surrounded by too many medical oncologists. We need another urologist to just balance it a little bit. Declan and I are just feeling, a little uncomfortable.
Come on, we love them. But, you know, we want, I think, on this topic to definitely bring urology into the topic. And that's why it's great to have Alex on the line as well, because the study we're talking about today, the population of patients we're talking about are urology patients. These are post-nephrectomy patients. And so this study is really important for us to digest and see how it impacts on our patients. So it's a great privilege to have these eminent guests here on the podcast today to talk about it. And Toni, we thought we would first of all invite you to just give us a brief reminder, and in the show notes and on YouTube we'll put links out to the paper and to other coverage of the paper. But do you mind just running through a bit about Keynote 564? What were the patients, what was the study design, and the key results?
So this was a phase 3 trial trying to ask the question if one more attempt at immunotherapy, now that we have new drugs, new immunotherapies for the past 5-10 years, checkpoint inhibitors with PD-1, PD-L1 inhibitor, CTLA-4 inhibitor, if they do better than the TKIs, if they do better than the cytokines. It's been 30 years since the first trial of cytokines. And for that, we designed Keynote 564, where patient with high risk, intermediate high or high risk renal cell cancer or M1 NED, which we believe at that time, and we continue to believe is an unmet need, would benefit from pembrolizumab. This was a phase 3 study of pembrolizumab versus placebo, almost enrolled 1,000 patients. The primary endpoint was disease-free survival. We looked at the usual culprits in terms of secondary endpoints such as overall survival, safety, quality of life. And the study, there was a press release followed by a plenary session at ASCO, and most recently a paper in the New England Journal of Medicine. Disease-free survival was prolonged with pembrolizumab over placebo, with a 32% decrease in the risk of recurrence or death. And, safety-wise, important always to look at safety. There was no signal that pembro in the adjuvant setting, specifically in renal cell cancer, there was no new really safety signals. And early data from quality of life did not show any decrease in quality of life. We had also a quick and quite early analysis of overall survival after only 51 events that showed a trend in the right direction. So that's, in a couple of words, what Keynote 564 showed.
Yeah, terrific. So Ben, we'll talk a little bit about the DFS, the big Kaplan-Meier, the key primary endpoint, but about the patient population. Can you tell us your thoughts? You manage a lot of these patients for us. You manage the metastatic renal cells for us, but for years we've been supporting adjuvant trials here and all around the world, and they've all failed pretty miserably. We can talk about S-Track, I suppose, but they have failed. So it's been an unmet need population. Tell us a little bit about your thoughts on this population in this study in particular.
So there's a real need, right? There's a real need in these patients. These patients, if they recur, they develop a terminal cancer that's no longer curable. So we'd love to be able to increase the number of patients who can be cured following a nephrectomy. And that's where there's a real need for the impressive adjuvant therapy. TKIs and cytokines have come and gone. They haven't really provided the benefit. This patient population's different to the metastatic patient population. You know, I think the adjuvant setting, patients are perhaps a little less tolerable, and that's what we saw with the TKI data. Patients weren't staying on the TKIs long enough to get perhaps the benefit we were hoping for. And we're hoping with the IO approach that patients will benefit from that more. IO is very exciting to patients and clinicians. You know, everyone wants a bit of IO, a bit of immunotherapy to help their cancer. And I think there's the data that Tony's presented is really impressive. I think it has the real potential to become practice changing. The question is the OS.
It is, and we'll get to the OS in a second, but I suppose thinking about the patient population, so it's reasonably heterogeneous. So it includes sort of three groups of patients. We have these are all post-nephrectomy. We have the intermediate and high risk, which is 86% of the study population. And these are patients who are either PT2 and high grade, grade 4, that's what I think we call intermediate, or high risk, which is PT3. Any grade, and this is 86% of the population, and then the other 14% are high risk PT4 or N1, or they've actually had metastatic disease resected, so they're M1 NED. Very interesting populations, but these 86%, the real big chunk of it, is intermediate and high risk. And I suppose the question I have as a urologist is, you know, is it really the whole population that are likely to benefit from adjuvant? Because clearly a concern I think we would have, Renu, is over-treatment. Like, what about the loads of the PT2s who maybe aren't going to relapse? Do you have a sense that the ones we've tended to want to support have been the PT3s or higher and above? And I'll ask Tony to comment about, Ben, we send you these patients, so what do you think about this population, the lower end of it?
Yeah, I guess I don't think they actually represent that large a proportion of patients, right? So I went back and looked at one of the private pathology providers here. They had about 300 nephrectomies over 3 years. And the proportion of that was actually just T2, and we didn't split the grades, but T2 was only about 80 out of the 100, 60 to 80 out of 100, the 300 patients. With the rest of it, so the 220, 230, was all T3 and beyond. So I'd be interested to know what Tony found in the study, but I don't think the T2 represents that larger proportion of patients.
Yeah, Tony, can you tell us a little more about that?
Yeah, T2 represented, T1 and T2 were less than 10% together. T2 was around 5-6%. This is in the supplement of the paper that was just published that unfortunately nobody reads. Everybody looks at Twitter. So this is a stab at Twitter, at Alex that has an extremely large Twitter followers, and nobody. It's less than 10% T2. Okay. But one thing I want to add, Declan, is that honestly, in any solid tumor, when you hear the word adjuvant, you hear the word overtreatment. No doubt, because surgery can cure, even in M1 NED, it can cure a significant number of patients. So this is not an issue for renal cell, for bladder, for prostate, an issue for breast cancer. There is always surgery alone, I would say, can cure a proportion of patients. Today, we do not know at all in any shape, way, or form using prognostic factors from the tumor or clinical prognostic factor that Alex actually and Rob Uzo and many other folks, have pioneered. We don't know who are the patient. We are starting to scratch the surface a bit with circulating tumor DNA. But if there is one tumor will be the last, will be renal cell cancer. Because this tumor doesn't shed DNA much, doesn't shed tumoral DNA. And even when you try to oversmart it and do bespoke assays that look at really the top mutation, et cetera, the sensitivity remains very low. And that's work from, colleagues of Alex at Fox Chase. So I think in renal, we're a bit safe to follow exactly the eligibility criteria of the trial.
Yeah, terrific.
Yeah, that makes more sense.
The OS is certainly it's dominated a lot of the conversation afterwards, hasn't it? So, Ben, what's your comment on that before we go to? Let's talk to Alex next about his thoughts on DFS and OS. But what are your thoughts on?
I think IO is very different to TKIs, right? So the way TKIs work, you'd hope there'd be a DFS benefit, and there wasn't across the board, and that speaks to tolerability of treatment. But you don't really expect an OS benefit. You look at the TKI studies in lung cancer, even in GIST. Dramatic DFS benefit, no real demonstrable OS benefit, but IO is different. Right? IO is getting your own immune system to go and get at these cancer cells if there are any residual cancer cells. And the trend from 564, there is a trend towards an overall survival benefit. There was never a trend in S-track. I think with more mature data, we'll see a significant overall survival benefit.
Yeah, good.
Yeah. Ben, can I just ask, what are your thoughts on categorizing M1 patients with localized disease patients?
I love it. I congratulate Toni for including these patients into this study because we need data on these patients. We know these patients are at high risk of recurring, and they're probably the ones that might gain the greatest benefit from an adjuvant approach.
Yeah, and I think the forest plot's showing that. But Alex, over to you. How's this being received in the US, and what are your thoughts on the DFS, I suppose, as a really valid endpoint?
Well, Declan, before I start and dive in, I mean, I know this is sort of a urologist-facing podcast. This is, I know my trainees now listen to you guys. This is, this is a big deal. So for me to come on, for me to get an invite to debate the Toni Chouieri, I just want to contextualize this to the urologist out there. This is, Toni is nice, and Toni mentors a lot of people, but Toni is a powerhouse. I mean, for those who don't know Toni's work, I mean, he's really like the supreme ruler of the Dana-Farber. Like, he's got ASCO by the horns. They do whatever Toni wants. I mean, he's got like 600 manuscripts just this year. The guy spits out New England Journal papers like AUA abstracts. John, did you even know that this was the New England Journal? Like, it's one of the,
he's preparing. He's preparing to kill me. That's how he starts.
No. So I mean, the guy's got a Wikipedia page. Look up Toni's Wikipedia page. The picture is really good. So there are people even. Toni knows that I worship guys like Elon Musk, but Toni doesn't know that there are like people have shrines in their office to not only Elon Musk, but to Toni as well. So this is, to ask me to debate him on a paradigm shifting paper is like feeding me to the proverbial wolves. I mean, thanks, Renu. Thanks, Declan. I really appreciate it.
Wow.
But honestly,
look at that photo.
Honestly, and oh, by the way, the photo, Rutul Patel was a medical student with me in clinic today, and I thank him for the props. So,
wow.
But honestly, this won't be too hard. Urologists, we're surgeons, and all surgeons are pragmatists. I mean, Toni's fancy forest plots and his hazard ratios, won't fool the surgeons to send all of our patients to, take pembrolizumab showers. I mean, it's just not what we're going to do. The data are preliminary. The risks are real. And the costs, Toni, are astronomical, right? So before we dive in, I would like to just ask Toni two questions. Okay, so two questions I have to start this, sort of back and forth here is: are we curing an additional number of patients, or are we delaying radiographic evidence of disease on the scans? Right, that's been the big debate in adjuvant. Yeah. And if it's the latter, if we're just delaying, would the effect be the same if we, would Declan alluded to, would the effect be the same if we gave the drug later? And I think those two questions are really going to be where the rubber hits the road with the urologist sending everybody for adjuvant. But just to say this, Toni walked into a graveyard of effort. I mean, how many trials were negative here, and how where people really thought that there's going to be really no adjuvant a therapy that's going to show this kind of signal. And huge congrats. This is an amazing achievement. But I really think that this question of, are we changing people's destiny and we're really curing more people, or are we just delaying the scans turning positive? And if it's the latter, can we just give the pembro later, or give it with, as Declan said, with a TKI together?
Yeah.
Well, after all that adulation, Tony, what's your reaction?
Oh
It's effusive.
my
You're,
God.
you're probably used to it, I suppose. But
No, not at all. I wish my mom was here. It's the only person that would have thrown everything else would have thrown eggs and tomato at me. So, but I have my picture. What do you say? That I think that these are very reasonable thought. I am the first one to admit that 24 months of median follow-up is short. And hopefully more follow-up, because despite that, I would say the event, and Alex and Declan and everybody, the event, a lot of them happen, most of them, the first 2 years. But if you look at many trials that were negative, like like Assure, ASTRAC was actually positive. But if you look at the ASTRAC, placebo, and Assure, and all these studies, despite most of the patient, a lot of them the first 2 years decrease, and the curve, is like this. Between year 3 and 5, a significant number of patients, do experience progression. So we certainly need more follow-up. But why I think as of today, and, I stand by that, and I think it will be proven to be right, that this is not just a delay, that there will be patients to be cured, is that the treatment with pembrolizumab was for a year. Now, and after a year, if you look at the curve from year one to year 2, I wish I can say year 1 to year 3 or 4, where there was no pembrolizumab given, the curves still do not merge. Now, you could argue that the pembrolizumab half-life is not like a TKI. There's an effect that, stays over a year. But I'm a bit optimistic here, unlike the studies earlier with adjuvant that had bevacizumab, where there was an early separation of the curve, and soon as you stop bevacizumab in other tumor like colorectal cancer, the curve have merged. So I am actually positive here, that I'm quite positive that things will continue the same. Now, if you are saying that, look, you need an overall survival benefit, I do respect that. That's not going to happen anytime soon. We have 51 events. The second interim analysis need an additional, I can't recall, like maybe 80, 90 events. So you're going to wait on that. But the early signs are positive if you discuss it with the patient. On the other hand, I would argue that we have seen, and we all deal with bladder cancer, here, we have seen adjuvant nivolumab in bladder cancer being FDA approved, and probably immediately accepted based on a disease-free survival benefit without even mention of an OS, knowing that there are other adjuvant approaches like platinum-based therapies. We can debate that forever, cisplatin, carboplatin, where I would think that adjuvant TKI is, way less importance than adjuvant platinum in renal cell than adjuvant platinum in high-risk bladder cancer. So those are my two things, but I think, Alex, it's a very reasonable thought. And folks that want OS have to wait for OS.
And I think that's what you see, a bit of a split in the community out there. I think the reaction from the medical oncology community at ASCO and on Twitter after the paper is very much, I think quantum leap is how Rana McKay, she did a beautiful editorial and a beautiful discussion at ASCO. Quantum leap, I think, is what she said. But many of us think, well, we need to wait for OS. And one of the reasons I think that's important is because the treatment of these patients when they do become metastatic has really advanced by, through people like yourself, Tony, and Tom Powell's senior author, who have shown us that combination IO, VEGF treatments are really, really, really effective for these patients when they do relapse. So that's my question to you about the control arm of this study, because obviously it straddles the eras. But do we have a sense in the control arm that when the patients do relapse, are they getting combination IOs, which we would consider to be standard of treatment? Because presuming that they're not actually getting, or many of them do not get a combination IO, it's not really the same as the way we manage the control arm nowadays, because when they relapse, they get combination IOs if they're intermediate and high risk and sort of patients. So do you have a sense of that is it reasonable to say that these patients, the control arm patients nowadays, will be getting different management to the control arm in this study, and that will explain why the OS would be different, I reckon, if you compare it against what would be contemporary standard of care.
And it's difficult, isn't it? Because just before we answer that, Tony, because a lot of these patients came from outside the US, so the management of the control arm is not necessarily uniform across all of them. Would that be correct, Tony?
Yes and no at the same time. Let me tell you why I have mixed feelings here. First of all, I mean, you mentioned there is, part in the paper buried somewhere where we look at subsequent therapy, but you're right. We don't look at who get combination, etc. And we looked at in these patients more so on placebo, obviously, because more patients on placebo did experience progression. We look at anti-cancer therapies, we look at radiation therapy, we look at surgery because some of the folks, recur and still surgical candidate, for metastatectomy. And between the placebo-treated patient or the placebo arm and the pembro arm, usually it's the same percentage of patients got anti-cancer therapy, got radiation, and got surgery. So we're fine like that. Now, will there be any patient that relapse and maybe never get something? Yes. And that is not something, even on the placebo, if there is more folks, which I don't know, yes, that means they should have been on adjuvant pembrolizumab. That means that if you relapse, you don't have the chance to get systemic therapy. We assume in big academic center where we all work, if our patient did experience progression, they're automatically gonna be salvaged by systemic therapy. First of all, we have no proof of that. Some progression are quite bad. They're associated with significant medical events, such as, DVTs, PEs, they can get treated. Some of them have relapses in the brain. It makes systemic therapy, harder. So as long as we treat, earlier, despite I would be the first to admit that there will be over-treatment, maybe this patient does not need or does have the time to get systemic therapy.
That's a real balance, isn't it? Over-treatment versus leaving it almost to a point where you can't treat or can't treat effectively. Sorry, Alex, you were going to say something.
I was just going to ask Tony about the control arm a little bit. So Tony, I mean, this is probably a question that comes up, but, people speak about the magnitude of the DFS for 564, but when you were designing this was right on the heels of STRAC. I mean, STRAC was published in 2016. You started enrolling in 2017. Can you sort of give us a little bit of insight? I mean, STRAC had an 8% over 5-year disease-free survival advantage to sunitinib. What kind of discussion took place about using sunitinib as the control instead of placebo?
Yeah, no, it was a big discussion. You are right. But the fact that the result with TKIs were completely inconsistent, all the trials beside ASTRAC were negative. We also tried to replicate ASTRAC inside ASSURE, a study, as you know, Fox Chase.
Naomi House paper, yeah.
Yeah, Naomi House paper, where we looked at not just the highest risk patient, because there is no doubt ASTRAC have higher risk patient than ASSURE. We looked at those patients. I mean, ASSURE is a 2,000 patient. So we looked at that. We looked at the highest of the highest risk, T4N1, and we looked at the quartile, the highest quartile of the dosing, because ASSURE, reduced the dose at some point, starting dose at 37.5. Well, ASTRAC didn't do that. We looked at that. I know it's a subgroup analysis, but when you have 2,000 patients and another drug, sorafenib, not just sunitinib, we did not find any effect on disease-free survival or overall survival. And other studies started coming negative. And also, don't forget, there's a discrepancy in ASSURE. ASSURE has a disease-free survival benefit by central review, but when you look at investigator assessment, there is no effect. The p-value is not significant. We felt, rightly so, because other adjuvant studies that were planned after or around the same time, we asked a lot of patient advocates, what do they think? We felt that not having treatment, rather having sunitinib, is very reasonable. And we consulted with the FDA, and there was also an NCI trial at that time ongoing by the name, it just finished accrual by the name Prosper. So we're looking heavily at it because, I'm sure all stakeholders with the NCI, the GU steering committee got involved, and we didn't feel we should replace that by sunitinib.
Yeah, and it's interesting with the S-track because it was a very positive endpoint for DFS and it did lead to FDA approval, yet there was no OS, of course. And listening to all the discussion after ASCO, that's the question, why hasn't the community adopted it as a standard of care? Because it has a DFS positive endpoint and it's FDA approved. But Ben, do you have any thoughts on that? We don't have access to it here, but what is the reason why the community rejected the positive DFS endpoint that led to FDA approval? Is it because they didn't like the OS, the fact that OS was missed?
I think it's a combination
S-track?
of things. I think yes, definitely the OS was probably the biggest factor, but the tolerability, the number of dose reductions, the number of patients who discontinued treatment, all those sorts of things kind of clouded it, and there wasn't minimal uptake in the community, I'd say.
And Renu, sorry.
I discussed S-track with all my high risk localized patients, and I mean the way I contextualize it to them is that there is, like Tony said, there's multiple trials, Prosper, that Everest. There were just a slew of trials that showed no advantage to adjuvant, but what S-track really showed, and the way I try to explain this to patients is that if you take a drug, for a year, you will have clean scans for an extra year. What we don't know if you're going to live longer if you take this drug. What we do know that in S-track, you basically had nearly 100% of patients had side effects. So we know we're going to get side effects. We know your scans are going to stay clean, for longer, but whether you're going to live longer, it's unclear. I think that discussion still applies to 564.
Yeah.
I hear Tony, and I trust Tony's intuition. I think he's probably right that it's going to really, the needle is going to move with this as the data mature. But I mean, there is not that many, events here. I mean, we have to admit that there is a massive overtreatment that's going to happen, and finding a biomarker, finding a way to better select these patients. I think that's probably the holy grail here, right?
Absolutely.
And that's what we're trying to really find. And, I think the most promising things here is no doubt in my mind, some form of a liquid biopsy circulating tumor DNA, if it pans out, because data is coming with colorectal cancer, but also from bladder cancer with, Tom Powell's paper in Nature, that this could be a way. Let's see, how many false positive and false negative they're going to be.
The last couple
that data in kidney, I know the bladder data well, it's really at every sort of milestone of disease progression, circulating tumor DNA has incredible predictive value. But in kidney, it's not really panning out from all the data that I know, right? It's a much more challenging problem.
Absolutely. So the same test, the test that is used in that elegant paper by Powell's and the colleagues at Roche is a bespoke assay. So you take the tumor while, you do Alex does the surgery, probably take him 15 minutes. He'll clean everything and the tumor gets sent. They look at the top 10, 15, 20 mutation. They create a test and they immediately look at it after surgery, maybe with the first appointment post-op with Alex, and that's a bespoke assay. That's a good assay. And this actually was tried in renal cell cancer with work from Alex Institution. For its Phil Abosh presented at ESMO 2019. It's not the same thing. The sensitivity and I believe the negative predictive value was very low, was below 50%. And that goes back to, what we found in renal cell cancer in general, when we looked at NGS versus other ways to look at cancer in the blood renal cell with methylated DNA that was found to be superior. However, these tests are not commercially available. Therefore, I think clinical factors and following eligibility criteria, specifically in renal cell cancer, are going to rule for the time being.
Toni, the last couple of things we wanted to talk about were, first of all, toxicity and side effects, because that's definitely a big concern for us urologists, Renu, isn't it? So,
yeah, exactly. And like you mentioned, Ben, it's the tolerability of these treatments and the fact of over-treatment and potentially avoiding these side effects in patients who may not need treatment until they become N1 or ever need treatment at all. How do we balance that?
And I acknowledge that's a really important consideration for you all as well. And I note that the comment that safety was in line with expectations is reassuring. But for some of us, becoming diabetic, for example, when your risk of relapse is maybe not that high, because 68% of these men don't relapse at 2 years. So. Yeah. So the toxicity thing, I know the messages are very strong on this, in line with expectations, but grade 3 to 5 toxicity, just give us your messages, Toni, and try and sell this to the urologists who are going to refer these patients. We're looking at this nice lady post-nephrectomy with a T2 thing for, and talk to us, how are we going to talk to this lady about toxicity before we send her to you?
Yeah, no, if we look at the toxicities overall, and here I would like to mention, when we put the grade 3 and 5, we have to take it with a grain of salt. Those grade 3, 5, the CTAC criteria were beautiful criteria done in the era of cytotoxic chemotherapy. They evolved, maybe for target therapy, they're fine, but for immunotherapy, I'm not too sure. And then the attribution, I want to be very careful of the attribution. In the past, we had, it was a bit more poetic, definitely related, probably related, possibly unrelated, definitely unrelated. Now you have to say related or unrelated. How are we going to know? At least I would say in the adjuvant setting, it's a bit easier than the metastatic setting where you have so many other, things going on. Having said so, the top 2 side effects were hypo and hyperthyroidism that were, manageable. Yeah. Where we start seeing things, are the pneumonitis. So we had 11 patients on the Pembro, 5 only on the placebo. Adrenal insufficiency, we had 10 patients versus 1. Diabetes, you mentioned, I had a patient that developed, didn't recur, was on Pembro, developed type 1 diabetes. The patient was pre-diabetic, if any, and developed type 1 diabetes on insulin. So we have 9 patients versus 0. The colitis, 8 patients versus 1. It tells you, how did this colitis happen on,
it happens,
placebo.
Yeah.
So, we do have these side effects. It's 1 year of therapy. And I mean, let me ask you this, why 1 year? You're probably going to ask me back. I mean, I think we all agreed at some point in the adjuvant setting, since the TKIs and before, that we do 1 year. I don't know why not 6 months versus 18 months versus 9 months and 2 weeks. I think you have to draw the line somewhere. But one of the things I want to tell you that with immunotherapy, we looked at, and it's probably, I would say, is as good, if not better, than the toxicities, the grading of the toxicity, is the use of high-dose systemic corticosteroid, which we define conventionally since these immunotherapy studies started by the equivalent of 40 milligram prednisone or higher. Because you want to exclude this patient that get 20 milligram for their scan for, as pre-medication. And that was 7%, 7.4% with Pembro, and it was less than 1% with placebo. So that's another way to look at the data, in my opinion, a bit more objectively.
Alex, any thoughts on that? And Ben, I'm going to ask you about the toxicity then.
Is this where I'm wearing my hat, where I'm trying to beat Toni in this debate?
Yeah, come on, go for it.
In the breast cancer patients, 3% of people die from these things, and we need to stop, not over-treating. But I mean, in reality, there's 1,000 patients in this trial, and I think the fact that there were no treatment-related deaths, I mean, it's very reassuring. I mean, they're clearly, it's suboptimal to get adrenal insufficiency, even hypothyroidism. But, and realistically, I mean, when you look at this and you look at S-track, I mean, the tolerability of this is much better.
Yeah, and I think a lot of commenters said that when, well-counseled patients are accepting of it. But Toni, I want to play you a clip from your mate, Tom Powell's, when he discussed this with you on the Euromigos podcast recently. Big shout out to them. We love your podcast.
And Tony, we had a conversation with James Larkin. We had a podcast with him, and what James said that the melanoma field are learning is that there are some irreversible, potentially devastating side effects, and you need to see those once or twice, and it really focuses the mind. What worries you most about that statement?
Yeah, I think it's worth revisiting, because you say the Pembro's for a year, but the type 1 diabetes is for life.
For life, yeah.
So it's small, it's devastating, but let me tell you, for us urologists, this is going to be very important about that, I think, and that's why I think the OS will be very important. Patients are very accepting of things like that when they have metastases, but if they have like a 68% chance of not having metastases at 2 years, and then they can be salvaged with a combination IO, I think, you know, that is still not answered in this type of trial, of course, because the control arm is not combination IO early. But Ben, have you comments on that toxicity side of it? Am I being too emotional about it?
Yeah, a couple of things. I guess you could relate it to the AstraZeneca COVID-19 vaccine. You know, there's a tiny chance that you'll get a serious toxicity, but you know, on a population level, you know, we'll get benefit from everyone being vaccinated. I think it's a discussion you have with your patients, don't you think, Tony? You know, this is part of informed consent. You know, we would recommend the immunotherapy. We would explain the small risks associated, the small serious risks associated, and we'll help the patient make a decision.
Yeah.
Yeah. Not to quote, my good friend James Larkin, but in melanoma, there is also a lot of use of ipilimumab.
Yes.
And maybe some of this was not the PD-1s, Ipi, and the melanoma doc, I don't know, maybe way stronger than us. They use 3 mg per kg. There has been some studies with 10 mg per kg. Of course, there is a dose effect of toxicity with Ipi, not much with CTLA-4, not much with PD-1 inhibitor. So that could be it. But I mean, there is no doubt it's a risk. So what we're doing with Keynote 564, hopefully we're going to get more follow-up, more data. You know, this is driven by events. And when you write a protocol and you say, the first time I wanted 260, this is how the protocol is written. You want 260 to 165 DFS event. If it's met, then now you want 140 OS events. So it's driven by event. So we have to wait for the next analysis. In the interim, we're going to generate quality of life data that is extensive, that's going to be at ESMO. There'll be an oral presentation, virtual, in Paris. We're going to look at high risk of recurrence. So among these patients you mentioned that are intermediate high, the 85%, among all the population, I want to see who has grade 4, who has sarcomatoid, what's their disease, what's their hazard ratio. Imagine if their hazard ratio is 0.8. That would be strange, because everything is telling us high-grade tumor, sarcomatoid tumor do way better with immunotherapy than TKI, for example, just because there's a lot of activation of the immune pathways there. The APM machinery, is, plentiful, PD-L1 expression. We're going to also look, I think that's very important at some point, at the central review, because, there was a discordance between central review and investigator assessment in ASTRA. So we're going to look in Keynote 564 at central review, and we hope it follows the pattern and it's positive. There are other adjuvant studies going on that we didn't talk about. Some of them finished accrual, where the primary endpoint is central review. And we can argue, should it be central? Should it be investigator assessment, or should it be both?
Yeah, fair enough.
Tony, you think that's why, Emotion started enrolling before you, I believe. You think that's why, 564 reported out sooner? Why do you think the difference? I mean, or is it the activity of the drug?
So many things. So the activity of the drug could be, there's a lot of studies where atezo actually in a similar setting, we can argue, Tom Paus and I have a lot of, about this in bladder. So there is second-line metastatic bladder where near identical but not identical trial. One with Pembro, was with atezo, different result. And there is, of course, the atezo or the PD-L1 inhibitor in general in renal cell. How did they fare compared to the PD-1, where the data showed OS benefit? So that could be the drug. Second, it could be the central review versus investigator. Investigator is what you do in clinic. You don't wait for bigger, and I do in clinic. While, in central review, you have to wait. Maybe your local radiologist know more. It doesn't mean the radiologist there centrally is right, but it's a different way to assess. And of course, you need all the scan read, etc. So if this didn't go at the same time as the trial was accruing, if it was left till the end, let me tell you, you can't hire 5,000 radiologists overnight. So the third thing is something we do not know, which could be around baseline characteristic. So I think, we may have more relapses just because by chance or by, the urology referral, we end up with higher risk disease. Despite we called it intermediate high, we may end up with higher risk disease. We may end up with more T4, M1 NED, and N+ than emotion trial. And that we will only know, it's probably unlikely, right? But we will only know when we know the baseline characteristic. But I expect emotion to be read quite soon. It's a smaller study.
Yeah, it will be. And Alex, the final question, you brought it up earlier, is cost. And so we were pleased to see that FDA are doing expedited review for this for consideration. And obviously, I'm sure it's going to get approved. We'll all be interested in the label. But this is expensive stuff, isn't it? So what are your thoughts on cost? And Ben, I'll answer that question then.
Yeah, I'll give a little bit sort of, that we did this project, or, one of our fellows sort of did this a few years ago, Ben Rista, who's now at University of Connecticut, and he really looked at all the adjuvant therapy out there. This is before, STRAC, before there was any approval for any systemic adjuvant treatment in GU. And if you really look under the hood and see what the oncology community accepts for, adjuvant therapy, like for instance, what's the disease-free survival benefit of tamoxifen versus placebo? It's 11%. What's the overall survival? It's 4%, right? I mean, in colorectal, the overall survival benefit is on the order of 1 to 3%. I mean, that is it. And it's widely accepted adjuvant therapy, right? So actually the bar is really low here to clear. Now, the problem is that for tamoxifen, monthly costs are about $13 US. Now, for, there's a nice paper on this by Tina Watson, who looked at, quality adjusted life years for combination therapy for, Pembrolizumab. And I mean, Tony, it's like over $250,000 for, one quality adjusted life year. And that's in a therapy that has an overall survival advantage, right? Over $250,000 when you have an overall survival advantage. Here, the costs are very similar, but we don't have an overall survival advantage. So by my calculation here of sort of a quality adjusted life years, it would cost an infinite amount of money to pay for one quality adjusted life year right now, right, with the data that we have now. So I think the costs here are a real problem that, I think we have to sort of adjudicate and figure out. I don't know what the cost considerations were, but, important for the audience to know that STRAC was, sunitinib in the adjuvant in the adjuvant setting was FDA approved, but it wasn't approved by the Europeans. And I'm curious to see how this, or in Australia, right? I don't think that was approved there either. Yeah. So I'm curious to see how this pans out for those reasons.
And Alex, the cost is not just linked to the drug, right? This is administered in a day therapy center. It's all that involved. All the extra blood tests we'll be doing. So there's quite a significant cost to society for giving this treatment. Yeah, it's for that reason, I think
the gastroenterologist, the pulmonologist,
endocrinologist.
Yeah, but look, that's what we have to figure out is how do we best, we can't figure that out today, but the tax dollar that, someone's going to have to pay for this stuff. And I think that's a really important consideration for society in general. And I think that's why, as you hint at, Alex, in STRAC, that did not lead to widespread reimbursement outside the US. And I think it's going to be the same with this, Ben. I'm totally shocked if this led to any type of approval here. They wouldn't even try without OS here. So it's very important. It's very important for us to see what happens in the US. But 3/4 of the patients in this study were outside the US, so it'll be very interesting to see how outside the US this is received by regulators and people who approve these sorts of things. Any final comments from you, gents? Tony, again, congratulations to you,
Tony,
all the investigators, all the patients involved in this study. Absolutely fantastic. It's a really, really important study, but we can tell that we're waiting for more data. Here we go. Thanks very much, Alex, showing us this lovely picture.
Tony, one last question to you. Are you going to reciprocate by having a picture of Alex in your office?
No, I am going to troll him right now on Twitter by saying to everyone and tag his wife and all his family and distant family that he has a picture of me in his office, which is just, I'm going to let Ben gonna defend me, Ben Davis.
It's absolutely fantastic.
It's on. Next podcast, bigger picture, Tony.
Oh my God. Thank you. It's
Great to have you
both. Everyone.
Yeah, well, look, congratulations again, and thanks very much. And that's all we got time for today. And thank you very much to Ben Tran for coming to join us as well today. Ben, it's been great to have you. That was fun.
Come back soon, Ben.
Yeah,
Fantastic. Thank you very much, everyone. That's all we have time for. We're posting this again as a YouTube video. That seemed to be popular when we did the last time, Renu, wasn't it?
Yeah, good.
So if you want more YouTube videos, just drop us a note and let us know as well. And otherwise, we'll talk to you again soon. Thank you very much, everybody.
Oh, do we lose Tony already?